Good evening, everyone. It is with great humility and under the weight of responsibility that I find myself here among such eminent speakers to moderate this session dedicated to regional anesthesia and war casualties. I must thank the speakers for their diligence and availability. Without them, Ezra couldn't have prepared this webinar in such a short notice. I must say, actually, in record time. For this reason, there's no associated CME credits to this webinar. This Ezra webinar is a response to the many requests for help received by Ezra from the Ukrainian anesthesiologists. I wish to greet and welcome all, as well as all anesthesiologists who find themselves in difficult situations of disaster and conflict. My esteemed guests will have 10 minutes each for their presentation. There will be some room for questions and answers after. So please place your questions on the Q&A section. This webinar will be recorded and shared in Ezra Academy, free for Ezra members. We will start with Dr. Dmytro Dmitriev. He's a professor in Vinnytsia National Medical University, the Department of Anesthesiology Intensive Care, Chief of Pain Medicine Department. He's also the director of the Ukrainian Society of Regional Anesthesia and Pain Medicine, and also the Ukrainian representative at Ezra Councils of Representatives. He will share with us some clinical cases from his experience during these war times. We will follow with Dr. Sean Dobson. He's an associate professor of anesthesiology, regional anesthesia and acute pain management in Wake Forest University School of Medicine. He will present the role of regional anesthesia from the field forward as the perspective of the anesthesiologist. And we will have the perspective of the surgeon from Dr. Nicholas Poulos, belonging to the Department of Orthopedic Surgery from Mayo Clinic in Rochester in Minnesota, USA. We'll follow with Dr. Ed Mariano. He's a professor of anesthesiology, perioperative and pain medicine in Stanford University School of Medicine. He's also the Chief Anesthesiology and Perioperative Care Service in Veterans Affairs Palo Alto Healthcare System and the President-elect of California Society of Anesthesiologists. He will talk to us about regional anesthesia and trauma and the main controversies. And finally, last but not least, we will have with us Dr. Chester Tripp Buckheimer III. He's on his last day before retirement. Thank you so much, Tripp, for finding the space to be here with us. He belongs till tomorrow to the Defense and Veterans Center of Integrative Pain Management, Department of Anesthesiology Uniformed Services, University in Rockville, Maryland. Well, and now it's time to give the floor to my esteemed guests. We will start with Dr. Dmytro. Thank you.
Thank you, Clara, for invitation for speech with this webinar. I working is difficult situation now. We have a lot that is patient with combat trauma. It's our region, in Vinnytsia region. We have a lot is soldier and civil people with combat trauma now, and I prepare as some clinical cases about this military trauma. I hope my colleagues answer and give you more information about this, how we use this regional anesthesia during this war, during this trauma, use regional anesthesia in different cases. In my first cases about is man people, 45 years, male, no allergics, who situated is admitted is military hospital, and patient has follow diagnosis. Patient has this combat trauma, amputation of the upper right limb, chest injury, and pneumothorax. And our department, our doctors have is short consilium, how, which type of anesthesia we can use in this patient. And first doctor, inhalation anesthesia. Second doctor, intravenous anesthesia, and maybe I with you colleagues as regional anesthesia include axillary block and paravertebral block for this patient. Maybe it's good option, maybe no, we don't know, but we start with regional anesthesia this patient and uses axillary block standard techniques. We can see is in my slide we can see is standard ultrasound scan for axillary block and use standard dosage of local anesthetic. We use standard techniques, use standards medication for these cases. It's second block which we use with this our patient as paravertebral block. Same techniques, no new techniques. We use only standard techniques because I think with during this war conflict, during when we don't enough time, we don't enough medication, we don't enough is same problem because we admit very many people, many patients admitted in our department. We can use only short blocks. We can use maybe it's single blocks only. But my colleagues maybe probably answer me how we treat or how we do use these blocks in our patients. Standard technique, standard ultrasounds scan. We use this local anesthetic. We can see is our ultrasound scan, how we use paravertebral block this patient. Next patients, age 52 years, male, allergic node, military hospital, combat trauma, injury, chest injury after bombing, pneumothorax, rib fracture. This patient has rib fracture, left side Tash 2, Tash 7, right side Tash 2, Tash 9. Yeah, and patient has this subcutaneous emphysema. Same problem. We think about inhalation anesthesia, we think about intravenous anesthesia, and we use, in these cases, regional anesthesia. We use bilateral erector spine block. This block is very simple for doctors. This block is provide is good anesthesia in this patient. After we use bilateral erector spine blocks, in this case, 7 times this patient. Maybe it's good idea if you use this continuous infusion, but we don't have. We have problem with staff. We have problem. We have is free time for use is continuous infusion for this patient. Maybe it's good idea if you use this continuous infusion this patient. Standard techniques uses local anesthetic. In more cases, we use bupivacaine standard dosage and uses local anesthetics approximately 20 to 30 milliliters is this 30 milliliters is these cases. Next cases is age 22, male, allergic no, military hospital, combat trauma, explosive wound, lower limb, right limb, sharp wound. It's patient has approximately 5 or 7 operation. I don't remember how much. Is on all time we use is just a second. We use is this electrical fast electrical block. These cases These blocks provide its good anesthesia in these patients. After first operations, we input is catheter for fast LACA and use continuous infusion and continuous anesthesia for this patient, continuous regional anesthesia for this patient. Provide good anesthesia during all time when patient has operation. Its next patients, history cases is 4, age 58 years, male, allergic no, bullet penetration, abdominal injury, and the patient has a peritonitis. This patient admitted is a very severe condition, and we think about these different techniques of anesthesia, and this patient receive regional anesthesia transversalis fast plane block. This block is our scan. We can see is local anesthetic. It's on anatomy of this patient. Standard techniques after single shot injection, standard dosage of local anesthetic. We use in standard techniques for transversus fast plane block for this patient. Maybe it's good idea if you use this QLB block and epidural anesthesia and other techniques, but we use this on these cases is transversalis fast plane block. And medical history cases 5, ages 18, male, none. This patient has combat trauma, fracture of the spine at the level of the TH8 and L1, penetration, abdominal injuries. We can see is MRI scan, fracture of vertebra. It's bullet fracture separate, and penetration is problem penetration abdominal injuries. As you can see, is operation is area when spine injury these patients. We decide no use regional anesthesia. These patients we use is intravenous anesthesia with protection is mechanical ventilation, and after operation we use this regional anesthesia. We use this QLB block when we have is enough time for this. Maybe it's home message. Maybe it's conclusion for my presentation. For combat trauma during work, we probably use simple block. It's a good option because we receive enough time for use this simple block. Use a single shot block, single shot injection. Difficult blocks require most cost, especially medical staff and training medical staff. Good option. Use regional anesthesia before admitted in the hospital. Use multimodal anesthesia. Maybe it's a good idea if you prospect group write is guidelines of how we treat this, how we use regional anesthesia during work, during trauma, during this situation, difficult situation. Thank you.
Thank you so much, Dmytro. We will follow now with Sean.
Okay. Hello again, I'm Sean Dobson. I'm an associate professor of anesthesiology at Wake Forest University in Winston-Salem, North Carolina. I'd like to thank Ezra for giving me the opportunity to speak here today. I'm going to talk about the role of regional anesthesia from the field forward, an anesthesiologist's perspective, some of the experience I had in Afghanistan. I have no disclosures for this talk today. My learning objectives for this talk are for you to understand the importance that regional anesthesia can play in a forward military care trauma setting, to understand the benefits that regional anesthesia can provide in this setting where other analgesic modalities may be limited, and the use of opioids may increase the risk of adverse events. Just a little background about myself. Before joining the faculty at Wake Forest University, I was a Navy anesthesiologist, and I was deployed as part of a Navy surgical team to Kunduz, Afghanistan, in the northeast quadrant of Afghanistan between April and October of 2012 in support of Operation Enduring Freedom. I was stationed at a Role 2 facility that was on a German provincial reconstruction team base and consisted of teams of American surgical team, a Dutch surgical team, and a German surgical team. Our facility was similar to a level 2 trauma center in the United States, or a community trauma center. And this is a hospital pictured here. The conflict in Afghanistan was particularly well suited for regional anesthesia as compared to earlier conflicts the United States was involved in that 50% of casualties were isolated extremity injuries. These changes in patterns in conflict over time are attributed to improvements in body armor and armored transport. Also, the use of regional anesthesia has increased in the battlefield because it's easier to perform regional anesthesia in austere settings due to technological advances, most notably in use of portable nerve simulators and more portable high-fidelity ultrasounds. Also, there has been an increase in the training of regional anesthesia in civilian and military settings, which has provided more anesthesiologists with this skill set. So what are the benefits of regional anesthesia and trauma? Well, they can include the supplementation to general anesthesia, which can reduce MAC requirements and reduce the amount of opioid administered during general anesthesia, which can potentially reduce the risk of respiratory depression postoperatively. Regional anesthesia can be used as a primary anesthetic, where general anesthesia may not be the best choice and may be able to avoid difficult airway situations. Regional anesthesia can be used to reduce sympathetic tone, improve hemodynamics, and improve perfusion, and can be especially beneficial in reimplantation of limbs to help with perfusion. In lower extremity injuries, regional anesthesia may reduce blood loss and may also decrease the incidence of deep venous thrombosis. Regional anesthesia can also provide superior postoperative pain relief and reduce dependence on the use of opioids postoperatively, and again, reduce or mitigate the risk of respiratory depression or other opioid-related side effects. Regional anesthesia may also have an impact on pain trajectories. This is a study that looked at casualties with isolated extremity injuries from the Iraq and Afghanistan conflicts and the pain trajectories of those who received a regional technique early after injury. The definition of early technique was within the first 7 days after injury, and those patients were represented by the blue line. They were compared to those who did not receive an early regional technique within the first 7 days after injury, and their pain trajectories were followed over 24 months. As you can see, those who received an early regional anesthetic had a lower pain trajectory as compared to those who did not, suggesting that early preemptive regional anesthesia can influence pain trajectories going forward. Another benefit of regional anesthetic techniques are particularly useful in transport setting of casualties, where monitoring of the patient may be difficult and the risk of respiratory depression from opioid administration may be higher. This is an example of a US C-130 military transport aircraft that's been designed for casualty transport. As you can see, it is a very cramped space with lots of patients and lots of noise in flight, which can make the monitoring of patients difficult. This is not an ideal environment for the use of opioids for analgesia due to the increased risk of respiratory depression associated with this environment. In Afghanistan, we had peripheral nerve catheter systems and portable infusion pumps that allowed us to place peripheral nerve catheters for transport of patients from the battlefield back to military treatment facilities in Europe and the United States, again, as an aid to mitigate the risk of opioid events in transport. Although regional anesthesia has benefits, there are some risks associated with regional anesthesia in the trauma patient. You can have hypotension with neuroaxial procedures, which may block the patient's ability to compensate in hypovolemic states. If a patient has received opioids and you block the pain stimulus or input, this may lead to respiratory depression. You may have the risk of intravascular injection, which can lead to local anesthetic toxicity in patients with polytrauma that might make it more difficult to resuscitate. You run the risk of pneumothorax with supraclavicular blocks, which could lead to tension pneumothorax under general anesthesia or lead to decompensation in a patient who has existing polytrauma. Hemodiaphragmatic paresis from interscaling blocks and supraclavicular blocks could lead to decompensation in trauma patients. Horner syndrome with interscaling blocks may complicate downstream neuroexaminations in patients who are presumed to potentially have a traumatic brain injury. If regional anesthesia is being used as a primary anesthetic in an unsecured airway situation, a patient with a full stomach may have risk of aspiration. And then there's also a potential risk of masking compartment syndrome. Our surgeons in Afghanistan would do fasciotomies on all of our patients that we had risk for compartment syndrome to mitigate that risk. So here's a sample of some of the patterns of injuries, upper extremity injuries I saw in Afghanistan from gunshot wounds and shrapnel injuries. As you can see that these types of injuries would be easily amenable to regional anesthetic techniques. For upper extremity blocks, I stuck to two go-to blocks while I was in Afghanistan, the axillary and infraclavicular block, to avoid the risk of phrenic nerve blockade, which could potentially potentiate decompensation of the patient. For single injection anesthetics, I would defer to the axillary block, and for catheters, I would place them at the infraclavicular site because the catheter would be anchored in the pectoralis muscles, which would help prevent dislodgement after placement. Here are some examples of lower extremity injuries that I saw in Afghanistan from improvised explosive devices. And we saw lots of children with burn injuries from open source flames from cooking. For lower extremity injuries, I would perform either ultrasound guided femoral blocks in combination with a subgluteal sciatic block or an adductor canal block with a popliteal sciatic block, depending on the location of injury. One difference in my practice in Afghanistan as compared to the United States was the vast majority of these blocks I placed under general anesthesia. And the reason for that was because of the severity of injury in these patients and language barriers that I had when I was interacting with patients, because the vast majority of my patients were Afghan. In Afghanistan, I had two different catheter sets available to me. And while I was there, since I was in an international hospital with other surgical teams, and I was deemed the regional expert, I was able to teach some of my NATO colleagues regional anesthesia catheter techniques. I found that those who are more novice at regional anesthesia found it easier to use the catheter over needle systems, and those where you have to thread the catheter through the needle. However, using the catheter over needle technique, these catheters are more likely to dislodge because you have a finite amount of catheter in the space, as opposed to when you use a catheter through needle technique, where we usually thread extra amount of catheter to give you some leeway if the catheter is to move so it is not moved away from the neuro bundle. Lastly, this is our surgical ward in Afghanistan. These are patients post-operative with orthopedic injuries. You can see it's a very cramped space. We had very limited monitoring. We also had limited staffing, nursing to take care of these patients, and the use of opioids was frowned upon because of, again, the risk of respiratory depression. If you look here in the foreground, this is a 6-year-old Afghan kid who had a lower extremity injury, and we had placed perioperative neural catheters intraoperatively, and we used syringe pumps to instill local anesthetic in our perineural catheters to provide postoperative analgesia. And again, in this setting, the use of regional anesthesia was very beneficial in preventing or mitigating risk with opioids. In summary, I hope that you learned that early regional anesthesia in the combat zone may have some influence in pain trajectories downstream. and that regional anesthesia can play a critical role in analgesic pathways where opioids are limited or the environment for monitoring is limited and the patients may be at increased risk of opioid-related events. Thank you.
Thank you so much, Sean. We will now move to our next speaker. It's going to be Dr. Nicholas Poulos.
Good evening. My name's Nick Poulos. I'm a assistant professor at the Mayo Clinic, orthopedic hand surgeon. Thanks for the opportunity to speak to those of you on the other side of the drape. The objective of my talk is really to help everyone understand the role regional anesthesia plays in a tertiary care setting when the rapid evacuation of casualties may not be possible. So why are we talking about this? Well, for the past 20 years, at least on the American side, this has been the pathway that we use to get casualties out of the wars in Iraq and Afghanistan back home. And we called this the military trauma care continuum, essentially how we get patients off of the X where they were injured back stateside to get their definitive care either at Long Stool or at a stateside military treatment facility. Some of this pathway is familiar to all of you, whether you have military experience or not. That first golden hour concept that's been around for nearly 50 years, going back to shock trauma and ATLS principles. And the military adds to this a little bit with what we Americans have been using called TCCC, which is essentially buddy care, self-care, evacuation of the casualty. And then everyone else on this call is familiar with the downstream effect of this, which is where do they go stateside? These are military treatment facilities, very similar in capabilities to civilian hospitals that most of us practice in. In the US, we have many military treatment facilities in the United States, but we also have several that we stand up in South America and Europe and Asia. And this really allows us to get our casualties, or was able to get our casualties from Iraq and Afghanistan to one of our treatment facilities within 24 to 72 hours for the Americans. Largely, these went to Long Stool in Germany or Walter Reed and Brooke Army Medical Centers in Bethesda and San Antonio. So in a forward deployed setting, a service member may have received 1 or 2 debridements in American before being flown back home to the United States. Of course, I'm supposed to be talking about the role of regional anesthesia as a surgeon in a forward deployed scenario, but I spent the first couple minutes talking about the transport because I think that's really where the biggest change or disruption in the treatment of casualties is going to be going forward for us and for our allies. Future operations with peer or near peer rivals are going to greatly limit our access to casualties. It's going to be difficult with casualty evacuation and difficulty sustaining our medical capabilities. And we're seeing this now, unfortunately, with our friends in the Ukraine, that military air superiority like we had in Iraq and Afghanistan is something we may have taken for granted and might not always be there. Further, some of our forward deployed medical settings, as you just saw in Dr. Dobson's talk, were quite advanced. They're not all MASH hospitals like you see on the old TV show. And in fact, the Roll 3 facility where I spent my time was impressively clean. We had CT scanners and at one time even an MRI machine. And needless to say, not all conflicts is that going to be possible. And so this military trauma care continuum may be disrupted and changed. And the bottom line is that many American casualties or our allies' casualties may be held up at smaller, less capable medical facilities awaiting transport. And that makes surgeons and anesthesiologists deployed to those settings responsible for their care for an extended period of time. And I think that's the big difference. What's unlikely to change is the type of injuries we'll see in future conflicts. As you can see, going back over 100 years now to World War I, limb trauma represents the plurality, if not the majority of injuries treated in modern conflicts. Many of these amenable to regional anesthesia. Some of the wounds we saw look very similar to things you might see in what we would call a level 1 trauma center in the United States: open calcaneus fractures, elbow fracture dislocations, loss of digits, open lower extremity fractures. Of course, other wounds do not look like what we usually see in a civilian environment. I think In the United States, the Boston Marathon bombing was eye-opening for a lot of the civilians that we might see things like this closer to home. What's really different about these injuries, the war injuries, from a surgeon perspective is, number one, how much dirtier these wounds can be. This is related to dust and the debris found in the wounds caused by the explosives that are leading to these injuries. And then number two is that the zone of injury is often underappreciated at the time of the initial debridement, meaning that what we see on our first debridement and looks healthy, when we come back a day or two later, might not be healthy. And so the bottom line is that these injuries often require multiple debridements, as highlighted by this study, which I think actually is probably fairly conservative or maybe even aggressive, I guess, the other side of it, looking at wound debridements and back placements of soft tissue wounds in Iraq, where the average number of debridements was a little over 2. I think in my experience, at least 2 debridements were necessary before closing most IED wounds. And so if we put these two together and say that the military trauma care continuum may be disrupted in the future and prevent rapid repatriation of our casualties with extremity trauma to safer areas, then many of these initial debridements and perhaps even the definitive orthopedic fixation will have to take place in a forward deployed setting. And so I'd ask all of you, and I think this is a great webinar, how will you treat them from an anesthetic perspective? We just saw this in Dr. Dobson's talk about the benefits of regional anesthesia. I was fortunate to have a regional anesthesiologist with me when I was forward deployed. Here's me pretending like I know how to do it, which I certainly don't. And just some words of encouragement for you. I know not everyone in the anesthesia field feels comfortable doing regional anesthesia, but I'd urge you to get all of your colleagues on board. If the orthopedic surgeons can do it, you can do it. And so I'm just going to leave you with a little example of some growth in the orthopedic field. You can see here, this is a chart showing that the number of fasciotomies greatly increased in 2005, which was when we initiated tourniquets in the field for all of our service members. So more people were coming back alive, but they had tourniquets on their legs necessitating fasciotomies. The problem was that not all of our forward deployed orthopedic surgeons knew how to do good solid fasciotomies. We don't all practice orthopedic trauma at level 1 trauma centers before we deploy. I'm a hand surgeon. I don't do lower extremity trauma generally back home. And so not everyone was trained up in this skilled technique. So the military put together an educational program to make sure that everyone that deployed understood how to do fasciotomies, that they were all speaking the same language, that they were all doing them the same way. And that certainly facilitates handoffs and communication. Currently, before any Navy orthopedic surgeon deploys as part of their maintenance of certification, they're required to take this new combat orthopedic trauma surgical course. It's a cadaveric course, so obviously it's fairly expensive. It reinforces the stereotypes that if you want to teach something to an orthopedic surgeon, you shouldn't put it in a book. We're very hands-on creatures. But it does go to show that we're teachable. And I think if we're teachable, you and your colleagues are teachable as well. So what's my surgeon's perspective on the role of regional anesthesia in forward deployed settings? Well, one, we're already seeing it today. Our adversaries may be peers or near peers when it comes to their military capabilities. This means we'll not necessarily have the air superiority we enjoyed in Iraq and Afghanistan. This will potentially lead to delays in how we transport our casualties out of theater. What's unlikely to change, though, is the type of injuries that I, as an orthopedic surgeon, treat. And so regional anesthesia, I think, will play an increasingly important role in future conflicts and casualties where our patients are unable to be rapidly evacuated from theater and end up receiving prolonged temporizing care or maybe even definitive care in a forward deployed setting. Again, I want to thank you for the opportunity to share my perspective. It's always a pleasure to collaborate with people outside the field. So thank you very much for putting this together.
Thank you so much, Nicholas. Now, please load your slides and share with us your presentation. Thank you.
Great. Thank you so much. It is incredibly humbling to be part of this panel. This is one of those moments, when you have imposter syndrome, and I just stand in awe of our colleagues and all the work that they've been doing, but especially our friends in Ukraine and Professor Dmitriev, who is actually living it even today. I'm here to talk about regional anesthesia and trauma and talk about some of the controversies. And I think of myself as really the trailer for our final speaker, Dr. Trip Buckenmeyer, who I've known for probably 16 or 17 years. Dr. Buckenmeyer is a retired colonel in the US Army, and it really is the person who pioneered in military advanced regional anesthesia and analgesia for the United States Armed Forces. And so he'll be talking specifically about that experience. I'm going to talk about my own personal experience. I started my career at a level 1 trauma center in San Diego, California. This is about as south as you can go. We had daily trauma, especially being so close to the border, bilateral lower extremities, gunshot wounds. We had the only burn unit in the county. And so this is really my first and really the intense experience taking care of patients with trauma. Now for the past decade plus, I've been working at Palo Alto Veterans Affairs healthcare system, where I'm the chief of anesthesiology. And we have one of the only polytrauma systems of care within the VA, going back to Dr. Poulos's continuum of care for the U.S. Armed Forces. And so we have there are patients who spend weeks to months at our campus rehabilitating after having multiple trauma injuries in the field. And so I won't talk about the benefits of regional anesthesia because our first speakers before me already went over it from the anesthesiologists and also from the surgeon's perspective. Just direct you to this article that I think really captures many of these benefits very well from some of our regional anesthesia colleagues and within ASRA, Drs. Gadsden and Warlick. So I thought I would just cover for a few minutes some of the controversies, and they've been mentioned already, but really delve into some of the data, at least the data that we have available. And I was going to talk about bleeding infection, nerve injury, and compartment syndrome, of course, with the last one being one of the most concerning potential complications for anyone who has very high impact extremity trauma. When we talk about bleeding infection, I was going to summarize this really only in a couple of minutes. And the truth is, I think that our patients, unfortunately, after having multiple injuries, however way you sustain them, tend to be bedbound for a long time. And so some of the concerns that we have as regional anesthesiologists, of course, is balancing the benefits of a peripheral block or peripheral catheter or neuraxial catheter for pain control with the potential risks of bleeding, which patients may have from underlying disease, but more commonly from pharmacologic prophylaxis, because patients who are bedbound with multiple injuries after having amputations, traumatic or surgical, are not going to be able to move around very much. And the risk of venous thromboembolic complications is very real and life-threatening. Now, when we talk about catheter infusion, I know there are some questions in the chat about the use of longer acting local anesthetics and adjuvants. The truth is some of the injuries that you've seen just in the webinar today are not going to be well managed with a block duration that is under 3 days, which is really the best we can hope for with the longer acting local anesthetic formulations and or adjuvants. These are perfect and very important indications for catheter infusion, which is what we have available today. As I mentioned, Dr. Buckenmeyer is really the pioneer in the use of a continuous local anesthetic infusion in the field, and then also for transport around the world for many of our injured service members who return to the United States. I found this is an incredible description, firsthand description of cases that Dr. Buckenmeyer and his colleagues had treated. And this is published over 15 years ago, looking at the duration of catheter infusion. I use this still today, even with our own fellows back at Stanford, talking about how safe it is to potentially leave catheters in a longer time. In this initial case series, catheters were in for an average of 9 days, and you can see the range up to 34 days. Because as Dr. Poulos mentions, our service members may be having multiple surgeries before they even leave an area of a conflict. And then those catheters can still be used for repeated anesthesia and pain control in the weeks to follow. The infection rate, actual infection for those catheters was just under 2%. Now let's talk about nerve injury. And I think nerve injury is always a concern. Nerve injury, of course, is multifactorial. When we see patients with the types of injuries that we've seen here on our screens, it's hard to imagine that they won't have nerve injury. If you look at just the reported occurrence rates of nerve injury related to regional anesthesia alone, they range fairly widely. We've seen as common as 3%. And we've also seen reports that range in the 1 in 4,000. What most of these studies actually lack is a true denominator, because many of our own registries only report complications in patients who received a nerve block. But the truth is, as we all know, that you can get nerve injuries from lots of other things, aside from nerve blocks. When we looked at our own data at the Veterans Affairs Palo Alto healthcare system, we actually took all surgical patients who had a nerve block and patients who didn't have a nerve block. And there was no associated risk or increased risk associated with having a nerve block versus not having a nerve block. The overall incidence of new peripheral nerve injury in inpatient surgical admissions at our hospital was just around 1%. And as I mentioned, no increased associated risk for nerve blocks. And I think what's important is really how you follow them. So the truth is, patients, especially these patients, after having war casualties, are going to have high risk of having a nerve injury of some source. We know that at least in our cohort, most of these injuries actually resolve within 3 months. They, of course, are not necessarily combat casualties and have a mixture of admission diagnoses. But I think the key here is really to continue to follow them. You really can't beat the importance of communication when it comes to complex patient care, which is really what we're talking about today. And remember that there are so many contributing factors, some of which we can mitigate and some of which we can't mitigate. And so I think that, as you can probably surmise from many of the discussions that we've already had this morning, there's so much of this is a gray area, and you're trying to use your best judgment to take good care of people and minimize risk. So talking about compartment syndrome just for the last minute or so, I think that this is really one that we are very concerned about in patients with high impact trauma. We know that the cycle of compartment syndrome is one that requires early detection. And as Dr. Dobson mentions, and also Dr. Poulos, that having surgeons skilled in fasciotomy and performing prophylactic fasciotomy in high-risk patients is one way to try to prevent this important and very limb-threatening complication. And this is something that we used as well when we had patients border trauma when I was in San Diego who had bilateral tib-fib fractures from border trauma. And these were ways that we could try to prevent these complications, especially when you have a high index of suspicion. The classic symptoms and signs of compartment syndrome are these 6 Ps: pain, pressure, pulselessness, paralysis, paresthesia, and pallor. And I think this is why there's some controversy about the use of regional anesthesia, because of course, pain is the first P. As far as we know from available evidence, that we currently do not have strong evidence that there is misdiagnosis of compartment syndrome due to regional analgesia. When we looked at some of these case reports that have been published so far, you'll see that this is a publication from our colleagues in Australia found only level 3 evidence. And unfortunately, or fortunately, this is really not a patient population in which you can conduct randomized clinical trials. So the truth is we will never have level 1 evidence, in my opinion. And based on these almost 30 case reports, there really is no compelling evidence. That doesn't mean that there's no risk. But I think that, since we're talking about one case versus another case, that every patient really has to be treated as an individual. So I think the things that I've taken away from my personal experience in trauma and from learning from our colleagues and taking care of our patients who've been sent back for rehab at our facility from war zones is that you really just have to have a system. You need to have very good communication. You need to be able to trust each other. And the truth is, having an acute pain service in which you have pain management and anesthesiology specialists with trauma surgeons and orthopedic surgeons who take care of these patients on a day-to-day basis just means you have more eyes on a patient and more people who are looking for potential complications and trying to intervene as soon as possible. Communication is the key, and I think that you can't eliminate that. That's really the key, I think, the most important and critical element of any successful system. And with that, I'll turn it over to my friend and colleague, Dr. Buckenmeyer.
Thank you, Ed. You flatter me by suggesting I'm a pioneer. I've learned in my 30+ career that nothing's done in a vacuum. And if I happen to see a little bit further at a certain point in history, it's by standing on the shoulders of giants like Alan Winnie, Roy Greengrass, Carlo Franco's, Steve Klein, Susan Steele, my mentors, and the many people that have taken these ideas and ran with them in America's conflicts and are doing so right now in Ukraine. And I am incredibly humbled, as many others have expressed here today, at what's going on right now today in Ukraine. And if these efforts at any level are able to provide some relief to the suffering that's going on right now from this unwarranted conflict, then I'm certainly all in. I do go by Trip rather than Chester, and I am about 48 hours away from retiring from the Department of Anesthesiology at the Uniformed Services University as a professor of anesthesiology. I have none of these. I'm not smart enough. And this will probably be the last time that I'll have to use a slide like this, because I won't be in the federal government and my opinions will truly be my own. And I won't have to tell you that they don't belong to the university, the Department of Defense, or I'm not representing the United States government. Unprecedented battlefield survival. Now, this is from an American viewpoint after 18 years of conflict. I am in no way comparing those 18 years to what's going on right now in Ukraine. I can tell you, as an old Army officer, the one thing I do know is the next war never looks like the war we just finished. But perhaps after 18 years of conflict, there's something we can glean from the experience that we have had in Iraq and Afghanistan. So certainly better trained medics, far forward, roles 1 and 2, as we call them, has been a huge benefit, contributing to a survival rate that's truly impressive. Improved equipment and regional anesthesia is no exception there. Our ability to do regional anesthesia, from where I first started learning from people that did it with a paresthesia technique. For those that you may not know, that's taking a needle and tickling the nerve and getting a reaction from the patient. No equipment involved, just a very good understanding of anatomy, to where we are today, where we can actually visualize our targets. Certainly improvements in evacuation, but as has been mentioned, we can always count on that. But really, what I would suggest to the audience today, that these efforts, in addition to increasing the survival rate, have we really been successful if we salvage the patient but subject them to a lifetime of chronic pain, debilitating pain? And certainly in the US military, our goal is to get people back in the fight, back to a useful life. And I think the earlier you make those decisions, and I will be showing some data that backs up my statement, the earlier you provide that analgesic care, comprehensive analgesic care, the better the outcomes are for many of these traumatic wounded. So I'm going to do what we often do in the United States military and give you the bottom line up front. And Ed already spilled the beans. It's all about the acute pain service. It's about establishing that system for effective pain management in an austere environment, so that trained medical personnel have the equipment and the training to respond to these disasters, whether war or natural. And I would suggest that from an American standpoint, the best place to center that activity is in the Role 3 facility, where it can support in both directions, further forward, roles 1 and 2, and evacuation of casualties with these forward services from an acute pain standpoint. So certainly there's a new face of regional anesthesia. This is actually the stimulator I used in the first patient, Brian Wilhelm, which I'll briefly mention. In a somewhat unsettling turn of events, this now exists in the Military Medical Museum at Walter Reed, which freaks me out a little bit. It still has my name tape on it. These micro processor infusion pumps made all the difference in our ability, not just with regional techniques, but also with patient-controlled analgesia and infusions of other analgesics, capability that we have not had before the last 18 years of conflict. And then the big boy in the block, the imaging system of the battlefield, the ultrasound machine. I am showing a sonocyte right here, not because I am recommending this, but it was developed by the US Army through a small business initiative where we asked for a laptop-sized ultrasound machine, and this is what was developed for us. And this is one of my personal favorites. It is a difficult environment, regardless of where you're practicing. These flight environments, we were transporting patients many thousands of miles, and we were subjecting some of these casualties early in the war to a terrible situation because we only had morphine. And it wasn't until we started developing these other ways of providing analgesia, particularly with local anesthetics with regional anesthesia, that we were able to deliver patients to our central area in Landstuhl, Germany, comfortably. And that was a big plus. And it's a routine activity today, as some of the previous speakers have mentioned. This is Brian Wilhelm, sort of in a collage. Again, you can see that stimulator on display at the Medical Museum. I want to focus down here in the lower left-hand corner. You don't really get the full impression of that picture. Brian Wilhelm is literally less than 12 hours from his wounding. He received a continuous peripheral nerve block, sciatic and lumbar plexus. All his buddies were in the room right now that were with him as a squad when he was wounded. And they weren't sad. It was not a somber moment. They were talking with each other. This is literally minutes after his surgery, which we did with a total IV anesthetic. This individual could be a participant in his evacuation if required. But more importantly, I'm considering the morale issues where his buddies were seeing the horrific wound that he received from a rocket-propelled grenade. He would go on to lose his leg, and yet he was so comfortable literally minutes after his operation and hours after the initial insult. And what I learned from this experience and getting Brian through our system is the need to have an acute pain service at all levels of care so that you can enjoy the benefits of these catheters. Early in the conflict, because we didn't have that, many of these catheters would be erroneously removed because people didn't know what they were looking at. Fortunately, today, the textbooks have been written, the information is there, and the examples are available from the American experience that can be applied to any number of natural disasters or conflicts. In a 3-month period, we did a study in Afghanistan where we actually were involved in the management. This is the acute pain service of over 40% of the cases. Many of those procedures were done without a general anesthetic, which is, of course, is a very resource intensive anesthetic. Because of time constraints, I'm not going to spend a lot of time here, but these articles are available to you if you're interested. We did go ahead and ask, what is the benefit to the trauma team at this Role 3 facility? You can see here a breakdown of the various people that we involved in this survey. And essentially, what they're saying to us is that they felt it was an important addition. I want to point out that the one group that was less enthusiastic was the nurses. And the reason is they have to take care of all of the pain, not just the pain that the acute pain service is involved. What this taught me is it truly has to be a service beyond just the regional anesthesia, and that you have to have a collaborative group of surgeons, nurses, and doctors working in this area. And this is another way of saying the same thing, but I'll point your attention to the bottom. Overall, the acute pain service had a significant impact on patient outcomes. And so we wanted to make sure that just because people felt that way, that we actually had data to support that. We looked at 124 amputees with our partners at Duke, And these were all combat trauma limb amputations. And I'll just, again, I'm not going to spend too much time on this. There's a lot of information in this article, but PTSD, depression, catastrophizing, and the absence of a regional anesthesia catheter contributed to neuropathic pain for years afterwards and increases in severity. And so I think that's a very profound statement right there. And other speakers today have already said that with other data that we've looked at in the past. I put this up here to remind us it's not just about the regional anesthesia. There are a lot of analgesics, simple things like IV paracetamol or Tylenol, managing wounds correctly with bandaging and splinting. We're developing new opioids, and opioids are not evil. Nobody's screaming for acupuncture after they've just had a leg blown off. Right now, sufentanil microtabs are being developed that I hope will replace the fentanyl lollipops that have been used to great effect in the last 18 years of conflict. Ketamine, I also think, is an underutilized medication in analgesia. And this may take a few people back, but if we have this acute pain service, we can start exploring the underutilized area of integrative medicine, things like acupuncture, massage, movement therapies that have a tremendous role in the rehabilitation and recovery of patients. And again, there are no bad opioids. There's just bad prescriptions and analgesic plans. We know who the enemy is when it comes to opioid addiction, and it's us. It's not the drugs. Finally, I'm going to spend no time here because this paper has already been discussed, but the conclusions of this article, a long-term 2-year evaluation of combat trauma, was regional anesthesia was a valuable pain management intervention, and the earlier it was applied, the better off overall the patient was. To make this happen, it requires leadership at all levels in the health system. It requires a cultural change to recognize that it's not good enough just for the casualty to survive, but they have to survive with some sort of analgesic management that will allow them to rehabilitate and recover in a meaningful way. And this requires some investment. This slide, I want to point out again, the most important bubble down there is acute pain nursing. Nursing has to have a role in this team. In my mind, they're the most important group of people in making the acute pain service work, but you'll see all the other folks that are involved. And it's not even easy when you're not in the United States. We did all this work. We actually developed, and this is the list right here, an analgesic case. And they told us we could have everything on it except the ultrasound machine because it was too expensive. And so this is something that you can't do on the cheap, but you do need to have those resources available and the consistency to provide the training. I'm not going to go back to the slide, but one of the pictures in the slides where we were working on an individual, there were 2 British officers who knew nothing about regional anesthesia that I was educating on the fly as we were dealing with casualties. And that's the model that I think should be followed in any conflict, in the next American conflict. And I would certainly recommend in the Ukraine conflict for those individuals who are out there doing it now to insist on this service and then begin training your colleagues. Thank you so much. And again, I'm very humbled to be a part of this, and I wish my colleagues in Ukraine every success. There was a request for more guidelines. 2 texts that I can recommend is Combat Anesthesia, the First 24 Hours. It's a Borden Institute text. If anyone wrote the Borden Institute, which is a federal medical organization, they would fall over themselves to give you free copies. And there's also the Military Advanced Regional Anesthesia and Analgesia text, currently the latest edition out of Oxford University Press. I have no financial interest in either of these texts that we're mentioning right now, but there are many guidelines and things to follow from an analgesic standpoint in both of those texts. Thank you very much.
Thank you so much. Thank you all for your brilliant presentations. As you can see, there are a lot of questions. Some of them you have been kindly answering. However, because some of them are very much insistently asked, I would like to address all the panel, considering specifically the compartment syndrome and the association with regional anesthesia, and with the concept that regional anesthesia might delay or even prevent that compartment syndrome is diagnosed and treated.
If I may, I'd like to have a stab at that.
Yes.
This was a huge concern in the original article that Ed Mariano provided, where we were looking at this. This, as you can imagine, was a huge concern amongst the surgeons. The reality during the time of that study, it was the acute pain service that not only initially recognized a developing compartment syndrome despite a continuous peripheral nerve block, but we got the surgical teams energized because it was, as Ed pointed out, another set of eyeballs on these patients on a daily basis, managing these catheters. And in fact, when we had a catheter that was previously working and then suddenly wasn't working, despite our efforts, we would immediately contact our surgical colleagues because that was an indication that we might have a developing compartment syndrome, and look at these patients. And then I want to finish by stating, if far forward there's any concern about a compartment syndrome developing in a trauma wound, it's my understanding from my orthopedic colleagues that that person should already have their fascial compartments open. So this should not even be an issue. But I'm not saying it's not a risk, but I'm saying it's a manageable risk, because my bottom line is we really can't block ischemic pain. And that if you are astute and you're following these patients closely, you'll be able to recognize these issues. Over.
Well, anyone else wants to share their opinion considering this?
Yeah, I think on the surgical side, I agree with that. I think, first of all, surgeons aren't necessarily great at diagnosing compartment syndrome either. We squeeze compartments and we say they're soft and compressible, so they don't have compartment syndrome, and that's really not a very good measure. There's certainly a role for better studies out here, for sure, leaving indwelling catheters from a regional anesthetic standpoint, but also putting in pressure catheters like an A-line into compartments. This is measurable. This is something that could be studied if we could get anesthesia and orthopedic surgery to collaborate. And then I would second, of course, what the Colonel said in terms of forward deployed settings. There's times where during transport, these patients aren't seen and aren't able to have compartment checks and be serially examined. And so the threshold in the forward deployed setting to perform a fasciotomy is really low, because I think the risk is outweighed by the benefit. Over.
Thank you. Well, Dmytro, I'm sorry. Oh, sorry, Ed, please go ahead.
No, I was just going to just add, I think that one thing that I didn't really delve into was just the importance of titratability. And so when you're thinking about your regional anesthetic and or analgesic technique, this is really where, if you have a patient whom you're concerned about, I mean, we've talked about all the preemptive interventions and some of the importance of communication, but it's also important that you manage that analgesic technique with really the most titratable option. And this is where I think that we've all been talking about continuous catheters versus putting all your eggs in one basket and giving a very dense, long-acting block. That might not be the best choice for a patient like that.
Okay. Dmytro, there are several questions addressed to you. Considering that many of your patients have suffered multiple injuries, how would you address the blocks? Would you sedate the patient before, or would you performing the blocks under general anesthetic? And have you had any complications, specifically local anesthetic systemic toxicity?
Yes, thank you for your questions. Indeed, we have many different problems when we use regional anesthesia. We use regional anesthesia before admitted is military hospital. We have that experience. My friend go eat block, fasciaca block himself during his conflict. Is incredible situation. We use this regional anesthesia during evacuation. Our patient, but maybe we use more general anesthesia during this. But we use this regional anesthesia is most cases is military hospital. When patients admitted is military hospital, we use regional anesthesia, multimodal anesthesia, and general anesthesia. It's same problem, but we don't receive a toxic problem. It's
well, for what I can understand,
because maybe we use this ultrasound guide. This reduces local anesthetics. Reduce dosage for local anesthetics.
What is your preferred local anesthetic, Dmytro? Do you have any preference, or what you use? What you have?
No, we not prepare it before local anesthetic. We use all near bed local anesthetic.
What do you have? You use bupivacaine, ropivacaine, lidocaine?
We use only bupivacaine because we don't have liposomal bupivacaine. We don't have now is ropivacaine. We use only bupivacaine.
You have been experienced shortage of equipment, of drugs?
Yeah, we use this pump, we use this elastic pump, we use this mechanical pumps for regional anesthesia. We have experience with our patients go outside military hospital with pump, it's no problem. If your patient might go to evade, use this pump too.
What have been your main complications? What main complications have you been dealing with during these times?
Is complication during regional anesthesia?
Yes. Or others.
It's more maybe it's infection, is nosocomial infection because it's a big problem. We admitted it's a lot of patients now. It's approximately 10 days ago, we admitted in our hospital 200 patients.
Well, thank you for mentioning the infection rate, because there also have been some questions of how to deal with the infections, not only related to regional anesthesia, that's what I can perceive, but also because there are multiple trauma, and trauma patients usually are more susceptible of having infection. So how would you address this prescription of antibiotics? Would you prolong it?
Yes, we prescribe us antibiotics before using regional anesthesia, before admitted in hospital. It's good practice with them.
Is there any special prescription that you advise that you are using?
Yeah, we use this antibiotics. We use this AG1 during this regional anesthesia. We use different medicines.
For example, Sean, do you prefer to use the antibiotics also for if you have a patient with a catheter in a very prolonged duration, or you just use it to deal with the infections related to the trauma itself?
So our practice in our trauma patients is if they're not going to the operating room to have a procedure and we're placing a perineural catheter, we'll give them prophylactic antibiotics at the time of the procedure. The vast majority of these patients after we place catheters are going to have repeated debridement procedures, and the surgeons are going to have them on continuing antibiotics. And that also goes true for my practice in the civilian world, with particularly with rib fracture patients who are still placing epidurals. I think there's a good study that came out of Europe that said prophylactic dosing of antibiotics in patients not going to the operating room helps prevent catheter infections if it's given at the time of placement.
Yeah. Okay. Thank you. Well, and other questions that have been that I have been identifying is the presence of subcutaneous emphysema and how this could, prevent or interfere with the technique for the placement of the block. And another question is also the presence of pneumothorax. Do you want any of you gentlemen want to develop this, please?
I can say that anytime there's air and you're trying to use ultrasound, it can be very difficult to image. It doesn't matter if it's subcutaneous emphysema. You can see this in other extremity traumas where there's active infection and potentially gas-producing bacteria. So air is your enemy with ultrasound because sound waves don't travel very well through air. So it can be very difficult, and you might want to choose an alternate technique that may not be ultrasound dependent.
Yes. Yeah, I totally agree. You can use nerve stimulation, for example, if it could help, to overcome this difficulty in visioning the structures. And also, the pneumothorax can be identified using the ultrasound. So, you have any experience?
To do a paravertebral block in a patient that has a pneumothorax. Mm-hmm. You'll provide them the analgesia, and you won't get it.
Test to you.
Yeah. And Mariano, one of the questions that has been addressed, this was directed to you. So what is your rate of dislocation of prolonged catheters?
Yeah, so I think that's a good question, because I think that a lot of the catheter retention, at least the techniques, really vary based on how much mobility you think a patient is going to have. I mean, I think that when you look at the pathway, the continuum of transport that Dr. Poulos and Dr. Buckmeyer had mentioned, that's a lot of movement. And so I think that there are various ways that we can try to keep catheters in longer. Of course, the equipment also varies. So I think Dr. Dobson mentioned that. And so if you have the option of having through the needle catheter technique, in which you can have more catheter length adjacent to the nerve, that's helpful for movement. You can tunnel catheters, you can suture catheters, you can use steri-strips, you can use skin glue, you can use adhesive dressings. There are lots of ways you can try to keep those in. For patients, like when we receive them, especially in our polytrauma unit, in which typically they're not extremely mobile, then oftentimes we don't necessarily suture those catheters. They tend to be fairly well retained, with or without subcutaneous tunneling, just skin adhesive and dressings. But a lot of it really depends on what the expected movement of the patient is going to be.
Okay. For what I can perceive, these patients, these trauma patients, are quite different from the surgical ones that we usually have in the OR, because when we are advising for adjuvants to prolong the block, I don't think maybe this could be suitable due to the long duration of the treatment that you want to provide to these patients that will, will be too long, for the duration of the adjuvants. Do any of you have any experience with the use of adjuvants or liposomal bupivacaine? No. Okay. So let's just move forward. So other questions that have been addressing is how would you assess? What would you do pre-block assessment? Do you need any blood counts, or were you specifically looking for coagulation problems? How would you address this
I would remind the audience that these are trauma patients, and so they're already going through primary and secondary surveys. And since you're part of the surgical team as an acute pain service, you're right there with the surgeon making these assessments. But because it is trauma, the macinations we would go through in a routine case, elective, is not an option in trauma. And so you have to make decisions based on the available information. Fortunately, modern technology provides us with an incredible amount of information very quickly. We were looking at, we had a TEG monitor when I was in Afghanistan, of all things. So we didn't have to guess or wait for PT-PTT. We knew whether or not the patient could clot, and we're making decisions based on real-time information. Obviously, that's not always available. So you have to go with what you're seeing. And in this aspect, and this is where I absolutely agree with what all the other speakers have been saying, communication is so vitally important. And the discussions between the surgical surgeons and the anesthesiologists as part of the surgical team and the nurses working with these patients, that's what provides quality decisions in this area. It's when people try to make these decisions in a vacuum that I think problems happen. And that's why, again, to beat this horse one last time, the acute pain service and the establishment of that team is so critically important for not just the success of regional anesthesia, but for good analgesic care of any casualty, not just in wartime, but in any hospital. And I think my colleagues would agree with that statement. Over.
No, everybody's nodding, saying yes. So
I totally agree
agree
with Trip, but I would also say if you're worried about coagulopathy and you don't have information available, you can also make smart choices about the block technique that you're going to perform. Maybe choose areas that are more compressible, better visualize with ultrasound guidance to avoid or decrease the risk of vessel puncture. I know even in civilian practice, we do lots of single shot nerve blocks on anticoagulated patients because it might be the better anesthetic choice than a general anesthetic due to the patient's comorbidities.
Mm-hmm. Yes, I totally agree with you. In fact, superficial blocks is for superficial blocks, coagulopathy is not actually absolute contraindication. Well, just one question came up that I really think it's very interesting. So will regional anesthesia delay management? What do you think about this, gentlemen?
Delay management of what?
Of surgery, of the intervention.
Absolutely not. And much to the, I'm going to get in trouble here with my British colleagues because they used to get very angry with me because the surgeons, we only had 3 operating bays and they wanted to get stuff done when we had multi-trauma. So they would ask me if I could do certain things with my magic bag of tricks so that they could take care of a traumatically amputated foot or something else, get started while the ORs were occupied. And we weren't supposed to do that, but you did what you needed to do. And so I would suggest it didn't delay anything. In fact, it facilitated moving casualties along, because while the most injured casualties were being operated appropriately on first, we would be establishing blocks, not only taking care of their pain preoperatively, but preparing them for surgery. And then because we had the block established, we often didn't have to delay using a general anesthetic. We could just get started. And one other comment, remember that it's not just about the mass casualties. It's the cleanup the next day and the day after and the day after, where you have to do these wound washouts and revisions and debridements. And when you have a catheter in place or you have a regional anesthesiologist available, those days can go very smoothly because you can move efficiently, you can dose those catheters and move things along. So the concept of delay is completely foreign to me when I'm talking about regional anesthesia. Over.
The portability is incredible. I mean, I remember during the horrendous Southern California wildfires, having the only burn unit in the county, almost every ward became a burn unit. And so we would just start moving around. You take your supplies, you place catheters out on the wards. I mean, everything we have is portable. And I agree with Dr. Buckenmeyer. I mean, you can start to take care of these patients even wherever they are. And I think that if anything, I think it facilitates the care and then the ongoing care, because I mean, taking care of some of these patients with multiple injuries, burns. I mean, they're going to need fairly regular dressing changes and pain control for weeks.
Thank you all. So my last, I have only two questions. So one more before I give you my last question. So just, does it make sense to talk about insurance coverage or medical legal implications associated with regional anesthesia and these casualties?
Again, it's trauma. Brian Wilhelm, the person who received the first American catheter, I actually tried to consent him because it's not a bad idea. And I had that same thought, and Brian solved that for me when he said, look, doc, he used an expletive. I know you're trying to do the right thing, but if you can make the pain go away, just make it go away. And that sounded like informed consent to me. And after that, I reminded myself that we're dealing with trauma, and that consent is implied as long as you're applying recognized standards. And the good news is those standards now exist. We're not guessing anymore on dosages or length of time because we had no data. That data is in existence now, and you can support yourself with that information. So from my standpoint, those aren't concerns.
Thank you. Well, and finally, any experience that you want to share after the care of these patients as a chronic pain management that you can find after this trauma? Do you have any experience, for example, treating patients where the regional anesthesia was placed early on their treatment, and those who unfortunately didn't have the availability of this acute pain management?
Well, I had mentioned and I'm sure we could probably do an entire new seminar on experiences. So I'll tell you a war story very briefly. Very early on, when we were developing the system for regional anesthesia early in the Iraq War, this is around 2003, I had placed a lumbar plexus catheter in a young soldier who had lost his leg. And I thought I had called ahead, which I often had to do back then, so that everybody understood what was coming. I even had a colleague who had trained at Duke like I had, and he knew this was coming, but he went to what's called a CASF, which is a combat air staging facility in Washington, D.C., where the casualties flew in. We didn't know they were going to stop there. And so a young medic looked at this catheter coming out of this guy's rump and called the doctor saying, oh my God, those idiots have placed an epidural and it's eroded through his ASS. And so that created quite a stir. Fortunately, my colleague went down and said, you guys relax, it's not an epidural, it's a peripheral nerve block. And so I think this just highlights what Ed and I think everybody's been saying, that the communication in not just regional anesthesia, but analgesia and pain management generally is so critically important, particularly when distances are involved. And even if we're talking Ukraine right now, they're still evacuating these casualties. And I'm sure Dmytro would agree with me that that communication is so essentially poignant, so that people understand these techniques, understand what you're doing, and are part of the team. Over.
Question about the chronicity or chronification of pain. I mean, I think this is what we see now in Veterans Affairs, with especially our patients with polytrauma, the amputees. I mean, first I would also want to point out that there's no good pain management without great mental health. And so I think that that's what we're seeing. All of our patients coming back. It's so important that that mental health is health care, and that we focus on that. As far as interventions for amputees, we offer the whole full range. I think one thing that's heartening that I've noticed is that our rehabilitation services, are top notch. I think that it makes me very proud to have been working in the Veterans Affairs system for over 10 years, because I think the quality of care we're providing our service members is incredible. They do fairly well in terms of pain management, even without intervention, but we do offer chronic pain interventions in a multimodal type of an approach. We also now, especially for some of our more recent combat injured polytrauma patients who come directly from, typically from Europe as the way station from war zones, we have the ability to offer peripheral neuromodulation. We're also performing clinical trials, as we have with continuous nerve blocks using extended duration infusions, which have been published. And so you'll see that Brian Ilfeld led that study that was partially DoD funded. And then we're just completing a study using cryoanalgesia for phantom limb pain for those patients. And then we're also exploring, as I mentioned, other interventions like neuromodulation.
Well, I think we're really over time. I really thank you all for being here and for sharing with us your experience and your knowledge. I don't know if you want to say some last words before we end our session. Well, just so for me, just thank you to my panelists. Thank you to all of you that are out there participating in this webinar. And I just want to send a few words for our colleagues that are managing these difficult times. They please accept my and our solidarity. And also, I want to send some words of courage to all the victims, also the patients that are our main goal and our main worries, and have all our knowledge and endeavors to overcome these difficult times. Well, and for all of you, thank you so much for being there. Thank you very much. And I hope to see you soon, and goodbye.